formulate new vaccines against SARS-CoV-2 and then want to decide on what variants to put in there if there is a need, I would think that beta, if tested under other conditions, would be a good candidate, since even for all the waves and then against the different people, there was high levels of neutralizing titer against beta. And so now we know that vaccination is important for neutralizing antibody production. Now, will vaccination also be important for the wide range of cross-neutralization that we see? Because what I've shown with the chi-square analysis is that there's just an association. But then for the different variants, will vaccination help? Now, this is just preliminary data. In the cost to produce neutralizing antibodies in the lab, so monoclonal antibodies, we selected some of the samples. So some of the plasma that express high levels of neutralizing antibodies, we selected their PBMCs for single cell sequencing. So this is preliminary data done by Kessie, one of Dr. Kwashi's PhD students. So we wanted, after analyzing the B cell receptors after sequencing, we realized that for between vaccinated and unvaccinated persons, there was a high B cell clone, unique B cell clone in the vaccinated persons than unvaccinated, meaning that the B cells that are produced in the vaccinated persons have wider ranges that are likely to produce antibodies that can neutralize or work against different variants if possible. So this is just preliminary data, but then it's pointing to the fact that vaccination may be a factor towards producing cross-neutralizing antibodies. We tried to test this between symptomatic and asymptomatics, which was the focus of Kessie's work, but then there was no difference. And then for the different waves, there's a slightly increasing level of B cell clones as the waves go. But then you realize that as the waves increase, more people were vaccinated. So it still points towards vaccination and antibody clone expansion. B cell clone expansion. Now that we know that we have cross-neutralizing, or patients produce cross-neutralizing antibodies against different variants, we want to know what the durability is. So we're able to produce these neutralizing antibodies that neutralize different variants. And for how long can the body hold these neutralizing antibodies for them to be potent? That is what durability is. So we have a project that is ongoing. So far we've collected samples from 21 donors. So this is a longitudinal study, unlike the previous one that was just a cross-sectional sample collection. So 18 of the participants were from COVID-19 patients, and then 22 were from vaccinees. And so for the vaccinees, we followed them through for 8 series of samples, while for the COVID-19 patients, we took just 6 series, up to 44 weeks. And all these samples were collected just recently during the Omicron stage, or the Omicron wave, so we don't have waves for earlier people. So what happens? So the preliminary data that we've been able to analyze shows that neutralizing antibodies can persist for up to 20 weeks in people who are vaccinated and infected. Now you find that the people in the cases in the red boxes are those that have not been infected, and so you'd see less neutralizing antibody across the series. Where the crosses are where we weren't able to get samples within the series for a particular patient. But you find that generally there is an increasing level up to week 20. That's when most of the times the neutralizing antibody levels will wane down. This could mean a lot of things, but then we can only say more after we've analyzed most of the data, because in the course of these series too, people can be infected or exposed to the virus that can also affect or boost the levels of neutralizing antibodies. But generally, after sufficient exposure to the antigen, it takes about at least 20 weeks for persons to hold the neutralizing antibodies before they start waning off. Now, for people who are not infected or did not show symptoms, but then came in for just vaccination, at day 0 before vaccination, so at this point they didn't have any vaccines taken, you find that it increases with time after they've taken the vaccine. But here we've only been able to analyze up to 8 weeks, and we find that generally people would have persistent neutralizing antibodies against beta and Omicron especially for up to 8 weeks. Now we are yet to analyze samples for up to 52 weeks and also test more samples and see what the trend truly looks like. But then my colleague after me, Eliza, will talk more about these series of antibodies or patients who have been followed for a longer time and even in a more larger cohort. So in summary, I believe I have I've shown that neutralizing antibody assessment is a good, neutralizing antibody titers is a good assessment for vaccination, because I've shown that vaccinated persons are more likely to express neutralizing antibodies. And so when we want to test the efficacy of a vaccine, it would be nice for us to use neutralizing antibody as one of the measures as well. And when we take a neutralizing antibody against SARS-CoV-2, whatever variant that infected, it's likely that that antibody can, so when we take plasma after a SARS-CoV-2 infection, it's likely that that plasma can neutralize more than one variant of SARS-CoV-2. So we can have broad neutralization. And then the neutralizing antibodies can persist for at least 20 weeks after exposure, and vaccination is able to increase unique B-cell clones, which is likely linked to broad neutralization. And on this note, I'd like to thank my lab, the Kwashi lab, that is led by Peter Kwashi, and then these members in the lab who contributed directly to this work. And our study participants and medical centers, especially the GIZ Medical Center, and then the Greater Accra Regional Hospital, and our partners from Glasgow, who did the single cell sequencing data for which we had the B-cell clone data from. And of course, these funders, the Wellcome Trust especially, and the Melinda and Bill Gates, and FCDO, that funded sample collection as well as all these ones. So on this note, I'd like to thank you and ask for questions. Thank you.
And we also like to thank Nana Prof. Ampofu, because a lot of the early sample collection particularly was with his guidance.
Hello.
And also Prof. Awandari.
One web.
All right. Any questions?
Hello. Thank you very much for the brilliant presentation. As a public health specialist, I'm always inclined to knowing what actually does this imply for the population. I see that you've chosen to take a longitudinal study to be able to observe if the patients or if the people still have neutralizing antibodies by the 52 weeks. But do you think you can actually use a predictive modeling in order to evaluate if they still need vaccination? And then in addition, I'm seeing that you took actually patients or people who were vaccinated. Was it once, twice? Do these people actually still need boosters? Or are they, or were these people, did these people have boosters? What is the implication of boosters in this population? And I mean, I have a lot of questions, but it's mainly, do we still need to vaccinate people? And do we still need to have much more boosters? And what does it imply for the patient?
Okay.
From your preliminary data.
Yes. So yeah, basically what you want to know is whether people need boosters to be fully protected from SARS-CoV-2 infection or the severe effects of SARS-CoV-2, because would always be exposed. So from the data so far, if what our preliminary data is showing is true, that after 20 weeks or whatever, after X number of weeks, if we have waned down neutralizing antibodies, and if we are hinging only on neutralizing antibodies and we find that after X number of weeks it's weighing down, and we are starting to find, we should be able to predict, if we have a large sample size, to predict that if after X number of weeks there is a decrease in neutralizing antibodies, then we should be expecting a spike or an increase in cases again, if the neutralizing antibodies will be a good measure for protection. You understand? So we can predict that after December 2024, there should be an increase in SARS-CoV-2 cases again, because at that time, almost everybody who had taken the vaccine would have waned off. So it will be a good predictive module so that we can prepare that if that happens, what can we do? If we boost, what does it happen again? If we give them another boost or introduce them to the antigen or however. So it's a good thing to prepare for the future. If after the end of the time it doesn't happen, we still were prepared. But then it's always a way to think forward and then to predict. Otherwise, there's no way to know what to do. Yes. Have I answered? Yes.
Let me add a little bit. So the other thing is that based on the sample sizes that we have, it's very hard to build a predictive model. But I think it's quite clear that if you are not vaccinated, you would have vaccination would add to the protection that you have from a natural infection. So if you're not vaccinated, definitely being vaccinated will still give you an added level of protection and durability. What is becoming clearer now from the cross-reactivity is that maybe boosting with different variants may not be as important as the frequency of boosting.
So my question has to do with the neutralization data you showed. It was hard to see because you had lots of points smashed down on your axis. So what I was interested in, I don't know if you can pull it up, but are the outliers driving your differences, or do you have, because it looked like you had a group of people who made no neutralization at all. Mm-hmm. So have you looked to see what those people are? Why is it that they were not able to neutralize? Because you seem to have two groups. You have some that are very high neutralizers and then some that don't neutralize at all. And yet you've grouped them together, right? So I wonder if you're actually conflating. Maybe there are a group of people who don't neutralize at all, and the question is why? Were they not exposed? Did they not make a response? Did the vaccine not work in them? Versus the people who neutralize really well. Because right now you have almost like a bimodal population. So I'm just curious if you tease that apart a bit.
So teasing them apart, most of them were unvaccinated people, but then all of them were exposed because they were COVID-19 patients. They tested for COVID and then were part. So the other thing too is that when we ran a total antibody, I should have showed that data. For total antibodies, some of them had total antibody levels, okay? But then when we do the neutralizing antibody titers, they don't have at all. So they were exposed, but then their antibodies that they produced were not neutralizing. And so we may want to look deep into what the factors are. And that is what the single cell sequencing data also we are trying to look at, because we took some of the patients that did not show neutralization at all to sequence their B cell receptors to see what it looks like.
Yeah, I think it would be interesting to look at, because and maybe display it differently, because right now the axis you're using, most of your points are very low to the axis. Mm-hmm. So it would be helpful to see if there is actually more of a spread. Okay. And then if there are a group of people who do not respond at all, who are unable to neutralize, even though they have antibodies. That's actually really interesting, right? It's like you have antibodies, but it's not working. Yeah. And what is it about those people that the antibodies don't work?
Right. All right.
All right, thank you, Irene. So, the other thing is, what we are going to have here is, because we have a company that is near and dear to us at WACCBIP, which is a private company, and also doing a very similar study focused on vaccine responses to SARS-CoV-2 vaccination. We wanted to follow on with that, and so there will be some similarities and some differences to what Dr. Alicia from Yamachi Biotech is going to present to us. I'm not going to mention the full name, so I'm sure you'll mention it when you're presenting.
Yes, thank you very much. Yeah, so I'm Elise Marie Kwesi-Malipaard, Dutch by the Canadian. Anyway, so I work at Yamachi as a research scientist, and at Yamachi our goal is to transform lives through innovative and inclusive science and technology. So Yamachi is Africa's first cancer biotech research company, launched 2021, headquartered here in Ghana, but also with labs in Nairobi, Kenya, and an office in Washington, D.C. And we work in the whole of Africa. So we have partnerships with hospitals, research centers in 9 African countries. And so